Suresh Nair, how you doing? Can you unmute? Suresh, your camera's not on. Hello, Suresh. Suresh Nair, how you doing? Can you unmute? Suresh, your camera's not on. Hello, Suresh. Okay. Suresh Nair, how you doing? Can you unmute? Suresh, your camera's not on. Hello, Suresh. Okay.
Hello.
Hello, can you hear me? Can you?
Yeah,
is that-
yeah. So I have to introduce Professor Atul Goel. So
Okay,
I am not seeing my face.
hold on.
You have to, you have to make me that this thing also not only audio but this thing also you have to give. You have given only audio thing to me.
Okay, I'll be with you in a second.
Hello.
Hello, can you hear me? Can you?
Yeah,
is that-
I can hear you. Yeah. I have to introduce Professor Atul Goel. So
Okay,
I am not seeing my face.
hold on.
You have to, you have to
Okay,
make me,
that's not running.
that this thing also not only audio but this thing also you have to give. You have given only audio thing to me.
Okay, I'll be with you in a second. Okay,
Thank you. Thank you.
okay, so let's address this problem. Hold on.
That's the problem.
No, hey, it's in like neurosurgery.
I am seeing you. I am
If
seeing
you,
you.
if you have the bleeder, you stop it. Okay, who are you?
I am Professor Suresh Nair.
Okay,
I
okay,
am
I've gotta let you in. Okay, hold on, I gotta let you in. You're not even
Yeah.
in. Suresh, are you Suresh Nair or
Yeah,
Suresh?
yes. Absolutely. Fine.
Okay, let me let you in there. That's why.
Yeah. Okay, join as panelists. I will join. Fine.
Yeah, I'm letting you in the panel right now. You're in now, right?
I will unmute myself. I am seeing you.
There you are. There you are.
તમારે જોવે છે અશોકભાઈ શું પાન ઓલો મસાલા ઓલો પાન કુટ્ટા બસ
We're trying to get Suresh Stankla in now.
बढ़िया था
Good morning,
Hi,
Chandra.
Suresh.
How
John
you doing,
Suresh
Chandra?
will be moderator and he will be the only person who will be able to control Professor Goel.
No. Am I the
Hold on,
moderator?
hold
No.
on.
Actually, good evening. Good evening, dear Pujari. Actually, I am supposed to introduce him. I don't know what is my role other than that. Again. Yeah. Are you hearing me, dear Pujari?
I can hear you quite well. Can you hear me at all?
Yeah. I can see your gray hair and hear you very well. And
It is not gray anymore. It is all white.
All wow. Okay.
Chandra,
great.
Chandra, move your camera. Move your camera so your whole face is in.
Yeah.
We're seeing, we're not, it's going to.
Dear Pujari, can you just tell me, 3 speakers are there for today's evening session. And what
Yes.
is the thing like, I am told that I have to introduce Professor Goel. I think Shangla will introduce you and I will be by.
Right. So the idea is that I will give a general overview.
Yeah.
It's a good idea, Chandra.
And then Atul is going to talk about difficult cases and what is his strategy. And then Cherian is going to talk about nodes, etc., etc.
Okay,
You have
fine.
heard my talk before, so nothing new for you.
So you will start the proceedings or I have to start introducing Atul and everybody, and after that somebody will introduce and you give the talk, or it is like that, or initially you will start the proceedings and then hand it over to me for introducing Atul. No, you are muted. You are muted. Dear Pujari, you are muted.
Is Abhida joining today, John?
Yeah,
Abhida,
yes,
Abhida will be there. Yeah, Abhida is there. Yeah. Abhida will be there.
Okay.
Chandra, I just texted her. You're prescient. You're reading my thoughts.
No, I got in. It took a couple of attempts before I could get in.
Oh,
So
yeah. I
maybe
see.
I was going on YouTube probably.
Yeah, Abby's coming in. You know, I guess Abby, yeah, okay. I'll introduce
Okay, I
Abby.
just want to change my background, maybe if it is possible. Let me
Yeah,
see.
yeah. You go to the video camera there at the bottom and
Okay.
open that menu up, and then choose virtual background. You see that? Choose virtual background.
Yes, yes.
Okay, there you go. There you go. Yeah.
So I'm talking from a big auditorium.
A bigger, yeah, but that's bigger. We have a bigger audience than that.
You're right.
Don't sell ourselves short.
Maybe my face is a little too big, so I'll probably
Yeah,
let it be this time.
yeah. Just your top of your head is showing there.
This looks more like New
You
Year
have
is
a
still
Christmas.
on.
Christmas is
Yeah.
over, Chandra.
We are still carrying on with our Christmas days. So I think I'll let this be.
Okay.
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 As long as they don't, do a disco kind of blinking, we are okay.
Yeah, that would be a little distracting. Yeah, blinking lights.
So did you get some rest over the New Year weekend?
Oh yeah. Yeah, I like to work in the holidays because no
I
one
know
else
you.
no one else is.
There has been no holiday for you at all. I can see you working day and night.
No, I love it, Chandra. It's like you in the OR. You lose track of time. You know what I mean?
Yes.
You know
Exactly. I think
you're in another world.
that's happening to you on this one now.
Yeah, yeah. You come to another world, and this was a really good touch you made with the moderators, because that brings more people in. That brings more people to look. The followers of the moderators.
No, I think what we'll do is we will choose the next topic. We'll choose the next topic and we'll find some more good friends to join us.
Yeah, okay.
So that we can have a good chat while we are going on.
Okay, well, whatever you guys feel is good for India neurosurgery education, we're all for it.
Yeah. No, Suresh Nair, Professor Suresh Nair is our biggest asset. He, in a way, can be called the one of the most, what should I say, sought after educator in India. If you take a residence poll, they will tell you that 90 out of 100 will choose Dr. Nair to give a talk on anything.
Really,
He is very well equipped to teach youngsters, and he, of course, has a lot of
I am
modern
listening
work
to, I am
as well,
listening
but
to
he's
you.
extremely good in his
All
extremely good in his basic neurology, neurosurgery. So even neurologists are afraid of him when they discuss some topic with him.
all is not true. It's not true. I am just an ordinary fellow, but very much interested in listening to Dio Pujari, Atul, and others. So my life is like that. And I have to fly tonight to UAE, and these people have made very strict, stringent rules that we have to reach airport 6 hours before flight starts. So they will do a rapid antigen again, and then only they will allow you to check in.
Where are you going?
I am going to Dubai. Dubai.
What meeting is this?
I have been invited by the Emirates Health Services to inspect some hospital, and also I am going for that.
You are going as visiting professor or some meeting?
Something like visiting, not professor, visiting faculty.
Okay.
Something like that. I should not tell. They have not written visiting professor or visiting faculty, I think. Something like that.
Excuse me, gentlemen. Chandra, I just want to run this thought by you. I would like to integrate this show every week into the training programs of India. Now, we did this with Deepak Gupta. We had a pediatric neurosurgery conference, and they televised it in the Ames Hospital. They televised it in the whole hospital. I was surprised. You know, all the TVs around and everything, that was being televised. But I think we need to bring it to the neurosurgery department so they can open a room to have the residents come in if they want to come in, you know, some kind of thing like that. And we got to plug into the Indian neurosurgery residency programs with this talk every week, so that they can go optionally, because I don't want to add to the neurosurgery schedule. But if they have a room with the computer on in the department, people can drop in, that kind of thing. Or if they're really ambitious, put it in the auditorium and put it on the auditorium screen in the hospital.
Sankla and I have joined John. What I have to, the only way I can respond to you is, you know, we are very fond of conducting this kind of activity every week in our own department. And it may be a little difficult that everybody will give that up and do this. This can be an additional program, and we can do it certainly once a month, or I don't know if it can be done more frequently. But for that, we will have to get some either major institutions or major groupings in neurosurgery involved.
The way to start,
probably get the pediatric neurosurgery. Dr. Sankla can get endoscopic neurosurgery. Dr. Suresh Nair can get skull-based neurosurgery groups. So all these groups can be, you know, because everybody is doing their own academic activities virtually every few weeks. I think every month, definitely everybody is doing it.
Well,
departmental activity goes on in a small way every day, but it definitely is there every week.
Well, I think one way to start, one possibility is to put it in your hospital, Atul's hospital, and Ike's hospital, because obviously you're going to have a little say in what goes on in your hospital. Just start with those 3 hospitals. We can talk about it later, or we can talk about it, because it'll be hard to, like you said, convince other hospitals. But if you went to them and you said, look, I'd like to put it on in the hospital lounge, in the neurosurgery surgery lounge during and make it optional. I think it might catch on with the neuro, because this is going to be an all-star show every week, every other week.
We can involve more and more departments as we go along. Yes.
Yeah. Just start with yours, Atul's, and Ike's hospital. Those 3. Sorry about that.
No, though we, you know, like to talk about standard of care and modern educational methods, many of us are still deeply rooted in individual kind of teaching, and have our own preferences how to get certain things across. So maybe this can be an additional activities for people to expose to many other departments. We have done that in some groups in the NSI forum, etc. But I think, yes, multiple departments can join who think alike, or who would like to join, or who would like to present cases. Something like that can be done.
Yeah.
You already have Manas. So you have conducted some programs for Manas Panigrahi as well, haven't you?
Yes. He's down south India, right? He's in Kerala.
He is down south in Hyderabad, but he's been our kind of education chief over the last 2-3 years. Now somebody else takes it up this year, so we'll have a chat about it.
Yeah. Good evening, Changla and I. That's hearing, yes, Changla and I, Cherian. They're all muted, I think. Yeah.
No, I'm not muted. I'm listening to you, and I can talk to you. Yeah. I'm okay.
Yeah.
I think so. Yeah, that's right. How are you, Suresh?
Fine.
So Dubai, what time?
How is COVID there in Bombay? COVID is
Bombay-
pretty bad, or here in Kerala, it's very bad.
Don't bring it from Dubai.
I have just recovered. I restarted work today. So I've had my 2 vaccinations. I've had my 2 COVID illnesses also.
No, you don't have to take booster, no? So did you take any this antiviral drugs for COVID?
Yes, I did.
Well, what did you take? That Molupil.
Molnupiravir, yes.
That is, 800 milligram, no? Daily for 5 days.
Correct.
Twice daily. Twice.
Twice
You
daily.
know everything, man.
That is, I know it. Everybody has to know that, no? 400 milligram BD for 5 days.
Correct.
And you didn't take a MAB, monoclonal antibody you didn't take.
Antibody cocktail too expensive.
Cocktail.
For you. Okay. Very expensive for you. For others, it is cheap. For you, it is very expensive. Okay. Why, nobody takes MAP? Because US was presumably Omicron, for which it is ineffective.
It is ineffective, right?
Yeah. MAP is ineffective for Omicron.
Omicron, yeah, that's right.
And Omicron, it presents with severe throat pain, malaise and all. No lung symptoms or anything. And
Yes.
the fever is mild, but malaise like that, and severe throat, pharyngitis like that. The other one, it is more of a respiratory lung infection.
Right, yeah. Right. Okay. Any new strain coming?
Any?
New strain, new virus?
It will keep on coming, no? We have to keep
Where is
on.
hype? I can't see hype. He is still hidden.
So,
Ike, you're here. Are you here, Ike? He may have stepped away.
let me ask you today evening, this is Hype has come. Hi, Hype, how are you?
Hello, sir.
Nice to
Absolutely
see
fine.
you. Nice to see you.
Good
How
morning,
is
Ike.
the department coming up?
I just went to a fort near here. It is one of Chhatrapati Shivaji's forts. We were admiring the way how he's built that fort. It's only 50 kilometers from here. I took my family, a beautiful place.
Your audio is not clear, right? Your audio is not clear.
Can you hear me now?
that's better,
Very
that's
well,
better.
very well. Now very well. Correct.
We just went with our, I am in COVID isolation now. I went to Gujarat to operate on a giant paraclinoid and everybody turned positive there after that. So I've had symptoms for only 1 day, but then I have been asked to go on isolation till next Thursday. So it is, we are going just to isolated places. So we went to a fort today. Nobody there. So amazing place. How this Chhatrapati Shivaji, this Maharashtra, I'm starting to become an admirer of this chap. See, really amazing way he's built these forts and water bodies around them. So I'm just going one by one. So just went to this place called Dathegad and this fort I saw. We walked up and really, truly amazing.
Very close to your place, correct?
Yeah. Very close to my place.
Yeah, that's right.
So good evening. Abhida is there. Abhida has joined. Yeah. Abhida.
Yes, sir.
Oh,
Hello,
Suresh
sir.
is
Hi,
introducing the
Hello,
thing.
sir.
Hi,
Hi,
Abhida.
Abby,
Hello,
can you introduce Suresh to
Yeah.
start?
It's Suresh, yeah.
Abby, can you do that?
Yeah.
Okay.
Are you lecturing Abhida first or what is happening?
No, I don't think I'm lecturing. I'll just start the session and then I think you all take over.
How you doing, Ike?
I am going to be talking under 10 minutes. One of my surgical residents will just introduce as to what is an exoscope. Then for the last 1 week, because in isolation, I have been trying out this AEOS Exoscope, and it is a really miraculous thing. It is the future for sure. I will not be surprised if the Exoscope will take over microscope in the next 10, 15 years. I mean, that would not be a surprise because the advantages are just tremendous. I mean, not only for the surgeon, for the assistant and for those who are watching. So we have gone through various trial procedures, culminating with anastomosis at almost 50 to 100x. So I'll be showing that. And then we have figured out how to use the exoscope with endoscope together, much more easier than the microscope actually, to use in lieu with endoscope. So we will talk 10 minutes about that. And I would want Chandra and Professor Goel to talk on anterior cranial fossa meningiomas. Professor Sankla is also here. So I would ask him also because I am using only 10 minutes of my time.
So I have you purchased it already?
I know, Johnny.
Have you purchased?
Yes, sir. We
Hi,
have purchased.
Parthiban.
Hi.
Hello, Dr. Goel.
Hello.
Right.
Hello.
Good
John.
morning.
Good evening, my
Good morning,
friends.
Atul.
Good morning in Miami. Good evening here in Mumbai.
Yeah.
Hello.
Really fantastic to see all of you actually.
Harshad Parekh is
Nice to
here.
see you. Yeah.
Some friends have already joined. Yes.
He's the best student.
Harshad.
He
He is a
always there.
very keen listener.
Chandrasekhar, you look like a COVID patient, eh?
Recovering COVID patient.
Yeah. I'm a patient.
My wife is after me to get shaved so that at least I look like a proper human being. But I think I'll wait another week or so.
So this is 7-day growth.
Yes. Hair are
How
still
many of
growing.
us are
That's
how many
good enough.
of us are positive now? How many of us are positive now?
I was positive before positive, but now I am really positive.
I'm positive, you're positive, and you
I
is
just
positive.
became negative.
I am
Okay.
not sure what is the status of mine because, I
Never
look okay.
tested.
It is difficult because all the patients who are coming are otherwise fine and jumping around, and you test them, they are positive. So you never know who is positive and who is not.
Probably Corona is Goel positive or something if you come in touch with the.
Harshad is there. I cannot see him. Harshad?
Hi Atul, how are you?
Hi, Harshad. Put
Great
your
to see you all. Great to see you all giants together.
I think we have 2 minutes more to go. Maybe we can. How do you want to go about it? We can. Professor Goel can and Chandra can let us know as to how we want to go about it.
Now, what the plan is that Suresh will introduce Dr. Dev Pujari.
No,
And-
you, Suresh. Oh, Suresh Angla. Okay, fine.
Yeah. Suresh Sankla. And
Yes,
then,
yes. So
Okay.
Dr. Ryer does not know me at all. So
I'm confused. I'm just going to introduce Abby.
So then after that, Suresh Nair will introduce me, and then Parthi will introduce IPE. And then
Yeah.
let us see how we go. Suresh Sankla also wants to present some cases and all. Let us see how we go further.
Okay.
Sure.
Okay, very good. You guys ready to start? Abby, are you there?
Yeah.
Yeah, I'm here.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach for the second India Neurosurgery Grand Rounds. We have a lot of personalities here, so let me introduce Abby Shah to moderate. Welcome, Abby.
Hello, John. Hello, everyone. We have a lot of people already logged in, and let us begin our show. So we have 3 speakers, and also Dr. Sankla will be presenting some cases. But to start the proceedings, first Dr. Suresh Sankla will introduce Dr. Dev Pujari. So as we all know, Dr. Sankla is a leading neurosurgeon in Mumbai, and he's interested in endoscopic surgery, and he does a lot of endoscopic work, as you will see in his presentation today. And we can start the proceedings. Dr. Sankla.
Thank you, Abida, and thank you, John, for giving me this opportunity to participate in this webinar. Let me introduce Professor Dev Pujari. He's the professor and head of department of neurosurgery at Bombay Hospital, Mumbai. He has been on the chairs of various national and international committees and departments. But particularly, presently, he is the chairman of WFNS Neuroendoscopic Section. I am so pleased to introduce him to you and invite him as the first speaker, and he's going to talk about the meningiomas of the anterior cranial fossa. Dr. Dev Pujari, please.
Thanks, Suresh, for a kind introduction. And without much further ado, I would share my screen. Am I visible and audible, John?
Yes, it's good.
Yep.
Okay. So what I'm going to do in the next few minutes is to talk to you broadly about what are the principles of surgical management of anterior cranial fossa meningiomas. And then we have all the stalwarts to discuss cases and alternative viewpoints with you. Though the first recorded case of meningioma was probably the olfactory groove meningioma operated by Durant in 1885, it was really Harvey Cushing who put a lot of emphasis on surgery of meningioma, and his sentence is very well recorded for posterity that there is nothing in the whole realm of neurosurgery more gratifying than the successful removal of a meningioma with subsequent functional recovery. So here we have a tumor which allows us probably to get a patient back almost completely to normal, however difficult the surgery may be. And that is what makes it so interesting, and that is what makes us all neurosurgeons wanting to do these kind of operation. I think when we talk specifically about skull-based meningiomas, it is important to understand that they are certainly not as easy as many of our convexity meningiomas, etc. And the main reasons for that are actually the risk factors which Dr. Laligam Shekhar and his team has put in a kind of paradigm to decide what will be the grade of this tumor and how do we get, what kind of excision do we expect, or what kind of prognosis we expect out of surgery in these patients. And these are optic apparatus involvement, cavernous sinus involvement, facial auditory involvement, caudal cranial nerve involvement, multiple cranial fossa involvement, so the bone barriers and the history of previous radiosurgery. As you will find that apart from history of previous radiosurgery and the fact that approach may be difficult because of the involvement of various cranial fossae, one of the most important worries you have is the cranial nerve dysfunction when you are dealing with this tumor. Today we are going to talk mainly about anterior cranial fossa meningioma, but the principles of skull-based surgery remain the same. You must understand the anatomy using optimal imaging. The surgical exposure should be like make every surgery like surface surgery, and try and attempt as less brain retraction as possible. Use of natural corridors, extradural approaches, and use of CSF drainage are the standard methods by which we try to achieve less brain retraction. And of course, skull-based reconstruction, whichever method you choose to operate upon, you must make sure that the skull base is compartmentalized properly from the paranasal sinuses or the nasopharyngeal cavity. So today's topic is anterior fossa meningiomas. They are not such a homogeneous group to call, talk about all of them in a very simple manner. And therefore, let us see how do we differentiate them and how do we look at them. One of the major reasons why the surgical approaches to midline skull base have had a kind of a pendulum from, being completely transcranial to becoming complete endonasal or skull base approaches, but it has gone through various stages. Most of us started off with bifrontal approaches, then we moved to the unilateral approaches, then to minimize the retraction, we thought about doing terional or what we call the supraorbital approach. And then we realized that it was not possible probably to see certain aspects of the tumor which required more inferior kind of an approach. So we tried to do more and more basal approaches. And then for all this, we needed to understand the interior aspect of skull base anatomy beautifully. And Dr. Suresh Nair and Dr. Ayub Cherian give beautiful lectures on this anatomy. Further to that, when our ENT surgeons and neurosurgeons joined us, they started talking about, trying to get to these areas where we were trying to get without brain retraction at all, by giving you transmaxillary approach and transoral approach, etc. So the quest for finding approaches existed for almost 2 decades before something else happened. And I think it is the fact that the endoscopic pituitary surgery started, but more importantly for skull-based meningiomas, the credit should go to Marty Weiss and the team in Los Angeles, which consisted of Fukushima and Goel at that time, who actually wrote up almost 100 cases done by the transnasal transsphenoidal approach for skull-based meningiomas. And all of these were microscopic surgery cases. Endoscopic surgery actually gave you a much better expanded view from frontal almost to foramen magnum, and in sagittal plane, it became indication for all of us who could understand not only the anatomy, but the fact that what is achievable, what is not achievable. When we are talking of what is achievable and non-achievable, one of the most important contribution to this has been made by the cadaveric dissections, which started at various places. The skull-based dissections not only remained about transcranial approaches, they also became about endoscopic skull-based approaches, and we had to learn the anatomy all over again. What we learned over so many years for the skull base from the top, we had to learn similar anatomy from below. And I think today's students are probably doubly burdened, unlike many of us who did not have to think about this in the beginning. Of course, apart from the anatomical corridors, there are several other radiological factors which are equally important, and I think they form an essential pre-surgical component of your planning. And the radiological factors, of course, are mostly MR, but also CT becomes important for you. The involvement of optic canal is an important fact apart from hyperostosis, extent of hyperostosis. When you're talking about brain, edema of the brain, especially this lion's mane kind of a sign where you get lot of edema in both the frontal lobes because of a large olfactory groove meningioma. These things give you a lot of idea about what problems to expect post-operatively. One of the other criteria which became important by Amin Kassam's description of it is the brain cuff, which probably is an important factor to make the endonasal surgery safe, especially for olfactory groove meningioma. And we have written about these in the meningioma of skull base book, where we have described these various factors and how they prognostically affect decompression or excision of the tumors. Currently, our image protocol mainly consists of delineating the tumor on MR with contrast images. You can see beautifully that this is a plenum sphenoidal meningioma where you can see the pituitary separately. You can see the dural tail, which is going further onto the anterior cranial base. you can see the whole tumor is homogeneous, and when you go to the AP films, you see that the tumor is more onto one side, especially the right side. The right eye is badly affected in this patient, and not only the optic nerve, but the tumor is going all around carotid here as well. So these are some of the things which you can see well. I also prefer to have a T2 MRI sequence, which tells me if the tumor is turning white as the rest of the white matter is turning, then I am more confident that this tumor is probably more easy for me to operate upon, because it will be soft and relatively avascular. And the axial sequences, as we just talked about, are very, very important to see the involvement of the optic canal, etc. Another important thing we always do whenever there is a tumor is a little eccentric, and even otherwise, it's a good policy to see the calcium within the tumor, the bone formation within the tumor, etc. But also the vessels. And you can see that the carotid bifurcation is almost engulfed in this tumor. See on this colorful CT angio images. One other thing which I thought I should just talk about briefly is the possibility of embolization. The possibility of embolization has been explored, and this is a very good meta-analysis you'll find in Neurosurgical Focus, which tells you that it may not be such a great idea if you have parenchymal vessels going into the, therefore, the well-known, what do you call them, anastomosis of external and internal carotid arteries should be studied properly before you decide that you want to give this. And though we were very fond of this earlier and have written about it in 90s, we have virtually stopped using preoperative embolization in this millennium. The other important thing which we used to do regularly was the insertion of a lumbar drain, which gave you a good kind of fallout. And I still use it occasionally when I do not see possibility of either the Sylvian fissure being opened or interhemispheric fissure being opened properly. In those cases, I still use this at least for some time, but not as liberally as before. One of the anterior cranial fossa meningioma, this can be called olfactory groove meningioma. This patient had almost absent olfaction on one side, while the other side it was relatively preserved. You can see some hyperostosis, and we went ahead and did this case by the right pterional approach. The right olfaction had gone, and we have been able to remove this tumor almost completely, as you can see on the post-operative scan. And you will find that there are some white matter changes, which the advocates of endoscopy always talk about, that this does not happen. But you have seen in the earlier scan also that there was already enough pre-operative white matter changes before we decide to operate on this patient, and this lady recovered without any neurological deficit. Cavallo and the Pittsburgh group both together actually published the first anatomical study to talk about feasibility of removing this tumor by extended endoscopic approaches. And they said that yes, it is a direct anatomical approach, but the relative restricted working space can be a problem. And this paper has come in 2005 when the Haddad flap was just being described. So cerebrospinal fluid leakage was considered a very, very major problem at that time. When these people in Naples wrote about their first 10 cases, they have shown 90% complete excision rate. And they had some 4 patients who require CSF leak repair to be redone. While from US, Dr. Liu has actually written a paper in 2007, and 2009, Kassam's group wrote a paper of almost 75 cases, and they have shown that these tumors can be wonderfully removed. And today, if we are really in a position to create a good nasoseptal flap, and we think that we have mastered the nasal reconstruction technique quite well, we can probably operate on these tumors, though we are reluctant because we find that extending Haddad flap up to there has not been very easily possible for us. When we have tried to do some extra drilling, even in a tuberculum sella meningioma, we thought it was a little difficult to repair this. And we will consider endonasal surgery only if the tumor is below 4 centimeters. It is reasonably soft tumor. limited lateral extension, and the patient has already lost olfaction. And this is a international kind of a figures which various people have given about surgical researchability of olfactory groove meningiomas. Only Liu has been able to get 100% excision rate in a endoscopic endonasal and supraorbital eyebrow kind of combined approach. And this Italian group has been able to get 56 cases transcranial excision with 100% success rate. Dr. Goel himself, who has the largest series published so far, in his 129 cases have described that 67% patients actually he has been able to excise completely for various reasons. So Gardner wrote about the series which Dr. Kasam and his colleagues have written, and this was a 2008 paper of 35 cases, and this is a 2011 paper of 75 cases, where they have shown that they have been able to get about 70+% patients where they were able to remove it completely. But they have also said that a tumor size above 40 millimeters, calcification in the lesion, absence of cortical vascular cuff can limit gross total resection in these patients. However, this phenomena took off and more people took it up to do these cases endonasally. We were one of their followers, and we started doing these for reasonably soft tumors. This patient said that whatever happens, doctor, please do not do a craniotomy for me. We had a reasonable good cortical cuff. We had a tumor which was restricted to a reasonable size, about 1 centimeter in front of the tuberculum, and we agreed to do this case. So basically it's a binostril, 2 surgeons, 4 hands kind of an approach, where you are trying to drill not only the sella, but you go at least 1 to 1.5 centimeters in front of the sella. You thin out the bone. I think one important thing that one learns while doing skull-based surgery is thin out the one shell, make it a shell, and then remove it gradually. Do not try to, push your drill in anywhere where you do not want it to go. So this patient, we have been able to expose enough of anterior cranial fossa. We have opened just above the pituitary. Then we have coagulated now the anterior intercavernous sinus, and we are entering the domain of the tumor, which is entirely in front of this. Very little of it is coming into the sella. And as soon as we start debulking, the tumor is fortunately soft enough for us. We are getting some CSF. Now, the most important thing is not to do blind curating. And therefore, the curate is being used mainly as a dissector, and the tumor is gradually being removed as it separates easily from the surrounding arachnoid. And you can actually start seeing both the optic nerves and free area. So first, a fasciolata graft has been put, then we have put the bone, and on top of that, we are putting the free flap at that time. I think this is one of the first few cases where, no, this is a nasal flap only. So Hadak flap has been put there, and this patient has healed well. This is the immediate postoperative CT scan. You can see that there is a nice space. There is no brain swelling at all. And this is a 3-month-old MRI, which shows that there is no enhancing lesion at all. And the flap has taken quite well, as you can see from the thick enhancing area at the floor of the sella. Schwartz actually talked about the fact that he compared the open transcranial approach for olfactory groove and plenum sphenoidale in their own unit, as 2 different surgeons were doing 2 different kinds of cases. However, this paper is very heavily criticized because they were not the same cases in terms of dimensions of the tumor, calcification in the tumor, and vascular involvement, and therefore it has not been given so much importance. One of the most important thing that is comes in your way is actually the involvement of the optic canal and the vessel. So this is a patient, a young lady, who insisted that we should at least give it a try, and we said if it is not possible, then we'll probably go transcranially. So here you can see that we have again opened in the frontal anterior cranial fossa apart from just going on top of the pituitary. You can see the top of the pituitary nicely, which is completely undisturbed. And we are removing this some amount of dura which is there stuck between the two at the anterior margin. Now you can see that as the tumor starts decompressing, you are able to get around the arachnoid, and you can start separating the tumor very easily from the right of from the left optic nerve and the carotid. We wanted to see beyond the tumor. Different kind instruments are definitely required apart from our regular ball dissectors, etc. The dura is being cut over the top. So it is not only a pull surgery. Initially it may have been, but you can virtually use all the instruments. You can cut across the tumor. You can do a proper bimanual dissection when you are doing this surgery. And I am becoming greedy. I am trying to take this tumor out, in one piece, which is really not a good idea. But we are getting good arachnoid bulging around us. And here we realize that the tumor is going beyond our bony opening, especially near the optic canal. So I am trying to increase the debulking by using endoscopic CUSA. Fortunately, all this equipment has become now available. Most of this works for microscopy as well, so you do not have to spend extra money to get this kind of equipment. And the tumor starts coming down further till we actually come very close to the optic canal. And now I decide to cut off the tumor and then deal with the tumor in the optic canal separately. So the tumor in the optic canal is being further disconnected. When I find that it is not possible to disconnect with a sharp dissector, then I use more drilling, open this wider, and then with the help of ball dissector, remove this tumor completely from the optic canal. So it is possible to remove the tumor from the optic canal. You can de-roof the optic canal well. You can take off the floor and you can take off the medial wall definitely. And in that sense, if you have a 180, in fact, even 360, 270 degrees invasion of the optic canal, you can still use this approach. A 360 degree, if you are going beyond laterally onto the optic canal, it is certainly not possible to do that. So this is the last portion of the tumor coming out with more dural excision. This is the last bit of tumor coming out. The dura is being coagulated. And then we go for the closure of the case. So we wrote about our first dozen cases, which is recently published in Neurology India. However, this kind of a tumor is virtually impossible to think about, not only because of the hyperostosis, because of the sheer size, and you can see that it is taking up almost half of the orbital roof. And this from a terional approach and managed to get it out reasonably well with some. This patient was almost virtually blind, but he recovered vision, at least for the first 2 years. When they followed up, he was able to walk by himself. Hyperostosis, a lot of people feel that can be an advantage in terms of endonasal approach if it is restricted only to base. But I think if there is a bone deposition within the tumor itself, it is very difficult, like in this particular case. So I have therefore decided to go with a small terional approach. You can see I am removing the tumor by the regular debulking and other methods. And then the question comes about, removing the tumor from the optic canal and the hyperostosis over here. So this hyperostotic area, and we have made sure that the whole tumor has come out of the optic canal, as you can see on the post-operative MRI. This patient, however, developed a recurrence almost, I think, 8 years later. No, sorry, this is another patient. This is a patient, again, had a reasonably a big hyperostosis, and I operated this by interhemispheric approach because of largely calcified tumor. Got this tumor out, I thought was completely, but this patient came 7 years later with a recurrence, and here we used a transnasal approach to remove the tumor completely, and we actually managed to preserve the diaphragm and remain extradural in this tumor by taking this kind of approach of removing both the sides separately. This is a post-operative picture, and this patient was electively radiated. We used a gamma knife plan because it was a relatively small area. If you have a lesion which is completely eccentric, like this kind of a tumor with only unilateral optic nerve involvement, I mean, many patients are very cosmetically oriented, and therefore I have used an eyebrow approach in this patient. Eyebrow approach gives you a big advantage of going completely at the skull base right in the beginning. And I think that is the biggest advantage. You can not only de-roof the optic canal well, you can vascularize the tumor very well. And here we have been able to get the whole tumor out without literally causing any kind of brain retraction at all. And the whole tumor has come out here, as you can see on the post-operative scan, and the scar which is seen at the first follow-up at 3 weeks. When you look at the surgical outcome at tuberculum cellae meningiomas, I think you have lots of people, including Professor Goel, onto this, who talk about removal between 70 to 90%. The only person who's talked about 100% tumor removal is a series by Arai from Tokyo many years ago with a 10% visual deterioration. But virtually everybody who's written about it by transcranial approach have written about a reasonable amount of visual deterioration after surgery, which is less than 4% in the series, large series coming from Kasam's place. And that is the main thrust of argument for people who are talking about using endonasal approach for tuberculum cellae meningiomas. Schroeder feels differently, that if you do a minimally invasive approach from the top and use endoscope to decompress the optic canal, your visual deterioration rate should not be high. In fact, he has shown 0% in a small series of 12 patients. Earlier, we had written about interhemispheric approach with using endoscope, and there we had, I think, only one patient out of some 37 patients who had some visual deterioration, but you can get a much better tumor excision, and you can see right down the slope of the sella. So I think one of the important factors which is now being mentioned is the slope of the sella. If you have an angle about 135 degrees, which is what very beautifully shown by Kelly from Santa Monica, and he decides which case to do transcranially or transsphenoidally, also taking this into consideration, that deepened sella with tubercle angle of less than 135 gives a very good endonasal removal. So this patient was actually done by transcranial because the endonasal angle was very, very flat, and we could remove this tumor from the top going into the sella. And after our interhemispheric series, when we started doing most of these as supraorbital or terional approach, we did another 47 cases and 12 cases of endonasal. That has recently been written about. I would just like to end by saying that, the simple scoring system, which has been used for cavernous ICA involvement, intercarotid distance, interfoveal distance, these are probably important while taking into consideration what you can do by an endonasal approach and what you can do by a transcranial approach. And the confidence in your own team is equally important. Mazda Turel with Fred Gentili, whom we recently lost, has written about this very well, that in the days of endonasal surgery, transcranial surgery still has a lot of value, because endonasal surgery is still restricted to a few centers who are doing their work, and therefore their work cannot be compared with the other work. This is Schwartz's paper, which talks about the fact that in plenum spinoidal and trabeculocerebral cell meningioma, in their own experience, they find that the visual kind of outcome is much better, and they have had virtually no CSF leaks. So they are saying that this is the approach to go for, very emphatically, when everybody else seems to be talking more about a balanced view today. Dr. Sankla has also written about his experience with transcranial and endonasal approach, and he'll give us his insights into this. And they have also shown that the visual outcome is much better in endonasal group compared to the transcranial group. Anyway, I like to show this slide because Joe Maroon way back in 90s had said that we are going to go through this stage, which approach will be accepted. I think it is not important. I think we have to believe that horses for courses. We have to find what is the correct approach for a particular patient and do that, like what we did. We recently did one of our last workshops actually was on anterior fossa meningiomas, and this meningioma we chose to do by a perional approach, while this we chose to do by endonasal approach, not only for the or that the audience can see both the approaches, but also because we thought that was the correct way to do it, as the anterocranial anterior cerebral arteries as well as the carotid on the left was engulfed by the tumor. With increased possibility of the coronal plane in endonasal approach, I don't know where we are heading, but I think whatever we are going to do, like the transcranial approaches, will probably go too far and then we will start retracting. So I think we have to find our ideal mix as to what we can do, and getting trained in both kind of approaches is probably the best way to do it. Thank you very much.
Okay, Abby, are you there?
Yeah. Thank you, sir, for this exhaustive lecture and discussion of both the approaches for anterior cranial fossa meningiomas. We'll have all the questions at the end. So I would like to now invite Professor Suresh Nair to introduce Professor Goel. Dr. Suresh Nair was former Dean of Sri Chitra Thirunal Institute of Medical Sciences and also the head of department, and he was the former president of the NSI. So Dr. Suresh Nair.
Thank you, Abhida, for giving me this opportunity. But you know, you have given me a very difficult task of introducing the legendary, the one and only Professor Atul Goel. Why difficult? Because I do not know where to start, as he has put a mark in each and every corner of neurosurgery. And talking about him is synonymous with taking coal to Newcastle. But I should confess, it is my distinct pleasure to do that. Professor Goel, my immediate successor as President of Neurological Society of India. Our previous speaker, Dio Pujari, was also President in 2013. So he was my immediate successor as President of Neurological Society of India, worked for more than 3.5 decades at the prestigious KEM hospital in Mumbai, putting it in the global neurosurgical map. After his superannuation, he is presently the head of neurosurgery at Leelavati Hospital, Mumbai, also professor at Mumbai Hospital. It is a sheer coincidence that both myself and Atul became full professor in 1999 and also HOD from head of the department from 1998. Although my HODship was cut short, it was for a brief period because when Dr. Bhattacharya, who was also appointed as professor, took over as HOD as he was senior to me. All of us are familiar with Atul's oratory skills and his magical surgical craftsmanship, which we have witnessed him performing in innumerable operative workshops. We all know that Atul is a great innovator and a philosopher, but little we know of the person who influenced him the most. And he was deeply influenced by the ideology anatomical and philosophical teachings of the late anatomy professor Dr. Manu Kothari, whom he calls his guru. Even as a young faculty, he had published so many technical notes that are referred even today. He revolutionized craniovertebral surgery. All of us know that by teaching neurosurgeons a transoral surgery for basilar invagination. His surgery of the past, way back in early 2000. I will tell a story. I was invited for the 69th Japanese Annual Congress at Fukuoka in 2009. And immediately following that, there was a meeting in Milan, where the Italian National Conference was going on, and they had invited Indians also. So I was also a participant. I had to take nearly some 20-hour flight from Fukuoka with Shanghai and reached Milan, straight to the hall where I saw great Atul Goel giving a lecture on basilar invagination. And when he told the audience that the transoral surgery is past, it's a story of the past, our grandfathers looking, Italian neurosurgeons, they are wonderstruck. They were looking what this man is telling. But all of us have learned his concepts about his pathogenesis of Chiari malformation. And for the first time, somebody assertively tells that it is because of C1, C2 instability. To cut short his astute mind, has revolutionized present-day craniovertebral junction surgery, and he can truly be called the father of craniovertebral surgery. Watching him operate any neurosurgical procedure is like watching a magician performing a fantastic feat. Why I adore him is he had never underestimated the innovative and creative minds of junior colleagues. He has close to, today I searched 801 publications in PubMed Index Journal, highest by any neuroscientist in the world. And I think his H index is 51. To those of you who don't know about H index, that is 51 of his publications have been cited 51 times or more. I don't think anybody will have that in the near future. And other thing is, what is very important is, an independent study done by the Stanford University scientists ranked him as the top 0.4% of the scientists in the world. Only 2 neurosurgeons from India could figure in that. Other than Atul, it was Rajasekhar. Then the same study not only ranked him as a #1 in neurosurgery and neurosciences in India, but also he was a #1 skull base and #2 neurospine surgeon in the world. While 5 of his articles are included in the highest cited 100 papers published in Neurology India, 2 articles published in Spine are among the 100 most influential publications in cervical spine research. For his outstanding contribution as a medical teacher, he was awarded the prestigious B.C. Roy National Award in 2003. Among the other prestigious accolades, he was given the International Ambassador Award by Congress of Neurological Surgeons at San Francisco in 2019, and the Dandy Medal for Distinguished Neurosurgery Services in 2018. And also he got an Outstanding Contribution Award by the Chinese Society of Neurosurgery in 2019. I am sure this I am 100% sure that is part of his successful career not only goes to his beloved wife Naina, who is a neuropathologist, but also to Abida. And they have been constant support to his whims and ideas and to his workaholic nature. I have to cut short his introduction because I have to take hold today to describe about Atul Goel. And today he is going to talk on his concepts about suprasellar meningiomas and parasellar meningiomas. And to remind you, Atul has the largest personal series on suprasellar meningiomas in the world. He has his own classification of tuberculum cellular, clinodal, and olfactory root meningiomas to predict operative difficulty. And may I invite my dear close friend, Professor Goel, to give his lecture. Professor Atul, please.
Suresh, you are little bit, you have, I can only say that you were talking from your heart. Maybe your love for me, your affection for me, your camaraderie, your closeness with me has, when you were speaking, it was not just reading. It was as if you are, so much happy about the whole thing. Nowadays, what happens is in India, if somebody has done, the other fellow is not so happy. But what I could see from your, introduction, that you were happy from inside, from what you were,
Absolutely, absolutely, Atul. Yeah.
and you were so proud, and it gives me a sense of humility, sense of I have to bend down my head in front of you for your love and affection for me for such a long time. And I must say that we have lived together, our subject, for so many years. We have loved our subject of neurosurgery, and we have walked the path so long, and we have still several more years. We will go with great love and affection. Suresh, thank you for your kind introduction and for your, whatever you have said is okay, but whatever you have said with love and affection and pride, that gives me much more, it gives me, the value is much more because of that. So, so I am going to talk to you about suprasellar meningiomas. Suprasellar meningiomas forms a very discrete group of meningiomas and a very important group of meningiomas. As regards meningiomas, we all neurosurgeons grow in the subject of neurosurgery by operating on meningiomas. We know how to operate meningiomas. We know how to debulk meningiomas, how to devascularize and dissect the meningiomas from adjoining structures. We learn neurosurgery with meningiomas and with gliomas. So these two things are part of our system. And meningiomas are important. And there is no question that meningiomas have to be learned, are difficult, they are dangerous, they can be vascular, they can be soft, they can give, we come out successfully, we come out having a disaster at hand, we can kill the person, we can give a new life. So all those facets of treatment we learn and we grow in our life of neurosurgery with meningiomas. Most important is, and what makes our subject very interesting is, no two meningiomas like fingerprints have ever been alike. So all meningiomas are different. Imagine if all meningiomas were the same, our life would have been not so interesting. All gliomas were the same, absolutely similar, it would not have been interesting. But every meningioma is different, and that is what God has made to keep our neurosurgical life at the edge. So these are the fingerprints, and you can, all the fingerprints in the whole world are different. I can say all meningiomas of the whole world are different. That is a different kind of a different way to look at it. This is another thing which is different in the whole world. Every nose print of a dog is different. Every voice is different. You see, every voice, my voice is different, Dr. Nair's voice is different, Dev Pujari's, every voice is different. Another beautiful thing that is different is the pinna, the shape of the pinna, the curvatures of the pinna. Every ear pinna is different. The other thing that you might not realize, that every hemisphere is different. The sulci and gyri, the pattern of sulci, we know of superior frontal, inferior frontal, middle frontal gyrus and all those things. They are absolutely having a discrete pattern, and they are different in each human being. So the question comes about meningioma. The issue is, can we actually cure meningioma? So this was one of my articles which you will like to read. And my feeling is, once a meningioma, always a meningioma. You think of removing a meningioma, you think of treating a patient with a meningioma, but in your mind you do not get this, that I will cure this person. Like you can never cure an acoustic tumor. Once an acoustic, always an acoustic. Total removal is, you can remove the tumor totally, but you cannot remove the potential of getting acoustic neurinoma again. So more important than removing the tumor in our dictionary, and particularly as I grow in the field of neurosurgery, is to preserve the function and preserve and improve the function of the patient. That should be the aim of surgery. And that is my current concept. You know, sometimes this is one beautiful article that you will like to read, and I recommend that you read this article. I read, this was a commentary I gave for World Neurosurgery, where a malignant spinal tumor, the concepts were discussed. And I said in my article that when you are treating a very malignant tumor, you have to, you don't have to bring a beautiful outcome images and show this is my fixation, this is my construct. You have to think a little bit differently. And if you read between the lines in this article, the maker of atomic bomb, and the maker of atomic bomb, you can imagine how much destruction that atomic bomb had created. And if you read what he said after the bomb was exploded, that whether he did it right or not, whether this discovery of atomic bomb was good for the public at large, and whether it was good for himself. So this kind of discussion, when we talk of meningiomas, we should think about the patient and nothing but the patient. And that is one thing that we have to be very clear about. So as regard meningioma, the key word is variability. Most important is every meningioma has different kind of clinical presentation. Every meningioma, like some with headache, some with more severe headache, some with visual loss, some with various kinds. So clinical presentation is different in every patient. And so is the radiological features. Every meningioma has different radiology. More important for a neurosurgeon is every meningioma has different patterns of surgical difficulties and different attitude towards that tumor. And when we remove the tumor, the pathology of each and every tumor is different. And more importantly is the outcome or the long-term outcome of each meningioma is different. So we have to think about meningiomas in that perspective. Regarding suprasellar meningioma, you see this is suprasellar meningioma, a little bit anterior towards the spinodal. This is a smallish size of meningioma. This is a little biggish meningioma, and you can see the arteries in vicinity, the anterior cerebral artery, the middle cerebral artery, the internal carotid artery. More important is the pituitary stalk, the optic apparatus. So this is a little bit middle size of tuberculum celli meningioma. So this is a huge size of tuberculum celli meningioma that you are seeing here. This is a meningioma which is quite a large tuberculum celli meningioma with a very big basal attachment. So the extent of basal attachment is absolutely important factor in the surgery of tuberculum celli meningiomas. You see, when you are coming from transcranial, you can see from this corner to this corner, and when you are coming from nose, you may not be able to see from this corner to this corner. Maybe if you are able to see, that may be a little difficult. You see, this is another tuberculum celli meningioma with a very wide basal attachment right up to the clivus. And the other thing that you see in tuberculum celli meningioma is this basal anostosis or hyperostosis of the basal bone. This is very common and a very diagnostic feature of tuberculum celli meningioma. This is my favorite slide, which I like to show, and I have shown this picture at least 100 times in my lectures. So this is a tuberculum celli meningioma. It looks like a wild lion, but you can tame this lion if you know the subject, if you have done enough of these cases. And this kind of a difficult tuberculum celli meningioma with anostosis may actually look like a flower. You remove the tumor and you give new life, a new vision to these patients. So every meningioma has to be learned how to remove, how to dissect, what not to do, and what should be done and how much should be done? These are very, very critical and very important issues in tuberculum celli meningioma. So you see, this is a tuberculum celli meningioma going up to planum sphenoidal and coming up anteriorly. See the wide basal attachment of this tumor. More anterior the tumor, more easier the surgical dissection. You see, this is a little bit anterior. This is not near the chiasm, more anterior towards the planum sphenoidal, towards the olfactory groove, more easier and more dissectable from the anterior circulation. So that is one very important point, more anterior, more the ease of dissection from the anterior circulation. This is a more classical type of tuberculum celli meningioma, where you see the pituitary gland separate from the tumor. And the diagnostic feature is the thickening or anastosis or hyperostosis of this bone. So this is one very important feature which differentiates tuberculum celli meningioma, say from pituitary tumor. Internal carotid artery, you see like eyes of a tiger, and the horns are the internal carotid artery and its branches. This is another very common type. If you see 200 tuberculum celli meningiomas, at least 50 or 60 maybe of this, exactly the same picture. You should differentiate it from pituitary tumor because of this hyperostosis at the base of the attachment. So this is very important. And if you see this tumor is not right in the center, it is a little bit eccentric. The question is, more eccentric the tumor, the dissection becomes more difficult. More the tumor in the midline, the dissection is relatively straightforward and more easier. I should not use the word straightforward or easy and all those things in neurosurgery, because nothing is easy, but in relative terms, more midline, more easy, more lateral or eccentric, more difficult. This is another tuberculum celli meningioma where the pituitary gland is not seen separately. This is another one where the pituitary gland is seen separately, and it is a very common and very characteristic type of tuberculum celli meningioma. This is another one where the basal structures, the pituitary gland and all those things are a little bit not seen clearly, but the features are very characteristic. The kind of encasement of internal carotid artery, anterior cerebral artery, these kind of things do not ever happen or very rarely happen in pituitary tumors. This is another tumor of tuberculum celli meningioma. You see the basal attachment, the vascularity coming from here. The basic thing is, when we are going to operate, we have to know where the tumor attachment is, and we have to dissect, and the vascularity comes from the base. You must remember very clearly when you are going to operate on these tumors that all the coagulation has to be at the base of the tumor. If you coagulate anything at the dome of the tumor, that is a wrong coagulation, and that is almost a disaster at hand. If you coagulate any one single branch or one single perforator of anterior cerebral artery during surgery, I will say that may just be the end of the whole story. So all the disconnection, all the coagulation has to be at the base, if at all. Reduce the coagulation as much as possible. That is one thing. The other thing is, the pituitary stalk is not almost always having a very discrete plane of separation from the tumor by a thick arachnoid membrane. I must tell you that I have never actually injured pituitary stalk ever in my lifetime in the surgery of tuberculum celli meningioma, because there is a discrete plane of dissection of the tumor from the pituitary stalk. This kind of anastosis, you see this anastosis, when this anastosis is present, the tumor is more firm in nature, more firm, and the dissection from the internal carotid artery and anterior cerebral artery complex may be a little bit more tricky in these cases. So anastosis indicates firmness of the tumor. The anastosis may be quite big. You see this kind of big anastosis indicates a firm tumor, and this relationship with the vessels can indicate a very difficult tumor at hand. This is a very rare form of tuberculum celli meningioma where it actually, I had thought that this is a pituitary tumor and had gone for a pituitary tumor in this case, but this turned out to be a meningioma. This kind of enlargement of the sella without significant bony hyperostosis is a relatively rare kind of situation. Pituitary gland can be separate from the tumor. And when it is separate, and if the tumor is arising from this area, you can see the bony overgrowth here. And bony overgrowth is one thing, and the vascularity is another thing. So this separate is a common kind of tumor. The other very frequently discussed issue is whether this bony hyperostosis should be removed or not. Whether for total tumor resection, where for Simpson grade 1 or Simpson grade 0 resection, whether you should remove this is another question that has to be answered. In my dictionary, I like to remove this when I'm not able to see this part of the tumor. I like to remove the anastosis, but for the sake of completeness of resection, I do not ever like to remove the anastosis. That is my personal opinion about it. Sometimes the tumor can be stuck to the pituitary gland, and this bone is the one which gives you the diagnosis that we are dealing with a tuberculum celli meningioma. Tuberculum celli meningiomas can be eccentric. You see, this is an eccentric on one side and almost like anterior clinoidal meningioma. And when this eccentric tumor, as I have mentioned, that the surgery becomes a little bit different. This is another eccentric from one side and involving the roof of cavernous sinus. You can see this tumor. This tumor becomes a little bit different. Another very important and very critical issue which is discussed in tuberculum celli meningioma is the optic canal involvement, an optic nerve and the extension of the tumor along the optic canal. This is very frequently discussed issue. And there are many articles which say that more than 35 to 40% of tuberculum celli meningiomas have an extension along the optic nerve. In my estimation, I will say that this figure is a little too high, and the extension or involvement and extension along the optic canal is about 15 to 17 or max about 20% to open the optic canal and go along the tumor to remove. That is, I will say 20% is also a little bit overestimate. So this is another eccentric tuberculum celli. You can call it anterior clinoid roof meningioma, but little bit eccentric. This is more eccentric, and this is tuberculum celli and lateral cavernous. And you see the hyperostosis of the tuberculum celli bone. Very rarely you see there is calcification along the dome of the tumor. I showed you calcification along the base of the tumor, but you see rarely you can have calcification along the dome of the tumor. And when you see this, I must tell you that the dissection from the anterior cerebral artery complex can be a little bit more difficult, not maybe little bit, maybe significantly more difficult. You see, this anterior cerebral artery can be a little tricky, and you must remember this. Anterior cerebral artery is the key for surgery in tuberculum celli meningioma. Like for acoustic, facial nerve is the key, and the whole dissection is based or focused on the status of facial nerve. Anterior cerebral artery and anterior communicating artery, this complex forms the basis of tuberculum celli surgery, meningioma surgery. And as I mentioned, one branch gone means patient gone. To that extent, the issues can be. So the entire surgery is focused on this complex. And my understanding is absolutely clear. I don't want to, annoy anybody or disturb the peace of anybody, but my feeling is absolutely clear that this dissection of anterior cerebral artery complex is much more safer by a transcranial route, and much, can be quite a dangerous issue if you are going for this tumor by a nasal route. And this complex, it is not just this complex, the perforators which come from the anterior circulation, from the A1, from the A2, from the ACOM, and each and every perforator has to be saved. That is from the bottom line. One is encasement of internal carotid artery. This happens almost quite a number of times, and this is relatively easier to dissect. I don't see any major difficulty in dissecting the internal carotid artery. The issue is anterior cerebral artery. And I must also say it looks like completely encased like in this picture, but it is quite in the lobulations of the tumor, and the dissection is not all that tricky or all that difficult. It is, there are various, it looks quite tricky and dangerous, but there are many issues regarding the tumor which makes it simple. And I must say that tuberculum celli meningioma, in my estimation, is quite a straightforward surgery. And I have no hesitation to say that none of my tuberculum celli meningioma surgery will take more than 45 minutes for complete resection. And this time is not always an issue in neurosurgery, but just for people to understand that it is not all that tricky or dangerous. So these are both sides, anterior cerebral artery and the issues can be understood. So what is important is when you are trying to plan the surgery, there are many things that you have to think about. One is the calcification. You see the calcification within the tumor, the black, you see the dark on T2 weighted image, it shows that this tumor is a relatively firm kind of tumor and which will make your surgical dissection little bit difficult. For me, the consistency of tumor rather than vascularity of the tumor is more important and more dangerous. So when you see a T2 dark image, you should remember that you are dealing with a little bit tricky and little bit difficult tumor. You see this calcification in the tumor, and when you have such a calcification, the whole tumor is calcified. You have to plan your surgery accordingly. You have to plan your surgery and plan your extent of resection, how much you will be able to resect or not. So this you have to know beforehand. This is a tumor with wide basal attachment and with multiple calcific tumors within the calcific spots within the tumor, making the tumor firm. But even in such cases, I must tell you, you learn how to demolish the tumor, learn how to break the tumor, learn how to devascularize the tumor, and you will be able to dissect and resect these tumors. Another important issue is the extent of edema around the tumor. You see, tuberculum celli and planum sphenoidal will seldom have this kind of edema around. And when you see this edema, you must remember that you are dealing with a rare kind of tumor, more aggressive form of tumor, and a surgically little bit more difficult form of tumor. So in the year 2004 or 5, I had written this series of 70 cases. Now my series is beyond 300 cases of tuberculum celli meningiomas, which, as has been mentioned, is the largest series on this subject. So in this paper of mine, which is a very highly cited paper, I had discussed about what makes the operation difficult. And accordingly, I had suggested a classification system. So this was my grading of suprasellar meningiomas, and the purpose of grading was to assess the extent of surgical difficulties, to assess the extent of tumor resectability, and to prognosticate the visual outcome. So this was about 17, 18 years ago when I had published this. And let me give you what were these parameters. One parameter was clinical parameter, and one parameter was radiological parameter. And I had given points. So if the person is 70 years, it makes the surgery a little bit more difficult, and I give little bit more points. So there were 3 points for patient who is more than 70 years, 2 points for between 60 and 70, 50 and 61 point, and majority of these tumors are in youngish age, about 30 to 40 and 40 to 50. That is the age group. So I don't give any points. So age, more the points I give to these patients. Another absolutely critical issue, which I have to tell you, and you must know properly this thing, duration of visual deficit. If the visual deficit is long, like more than 5 years, the surgery is difficult. If the visual deficit is less than 3 months, the surgery is relatively easier. So the duration of visual symptoms makes the surgery difficult or not difficult. We cannot just see the scan, okay, the tumor, but duration of visual deficit is a very important, and I give more points for more duration. Another very fantastic point is about the difficulty in more the visual deficit, more severe the visual deficit, more difficult the surgery. So I had given partial visual deficit. Like if the vision is finger counting at 3 feet, if it is less than that, it is severe visual deficit. If it is more than 3 feet, it is partial visual deficit. So partial visual deficit, the points I gave less, and severe visual deficit in one eye, I gave more points. And so these kind of points I gave. And it is needless to say that more the visual deficit in a person, more difficult will be your operation. Suppose the person is completely blind before the operation. Believe me, this operation will be a dangerous operation for you. If the person has little bit vision, it is relatively simpler. Another very less finding is hemispheric deficit like hemiparesis or convulsions. If they have, then I gave more points. It seldom happens in tuberculum. Altered sensorium, altered behavior, seizures, endocrine disturbances are relatively rare, or this was my figures which I talked about at that time, but now I think my numbers will be much less than what has been mentioned now. If the person has diabetes, hypertension, pregnancy is another issue. When there is a patient is pregnant, the tumor is more vascular and more edema, so I give more points. Calcification in the tumor, paranasal sinuses, when it is involved, the tumor is more difficult and more aggressive in nature, optic canal involvement, hyperostosis. And if you see this multiplicity, if the tumors are multiple, I give -1 point because the surgery is relatively simpler. Vascular encasement, anterior cerebral, internal carotid, I see on both sides, I give some points. Hydrocephalus, mild, moderate, severe, I give some points. Edema, I give some points. So according, then I calculate, add up all the points and grade these tumors. Now, if you see grade 1 and grade 3, if endoscopic surgery has been indicated by the world of endoscopic neurosurgeons, they will like to do not more than grade 1 tumor, and that indication is for grade 1 tumor, if at all. My indication is for all grades of tuberculum celli meningioma, there is one and only one approach, and that is transcranial frontal on the side of the tumor, of the worst vision. So my approach is for this tumor, this is a tumor, this is the large tumor with wide basal attachment. I have already told you many a times the attachment may be extending right anteriorly on the planum sphenoidal. So you will think that the attachment is only up till here, but it may be along the dura. There may be a lot of attachment which you have to coagulate. My approach will be frontal on the side of worse vision. If the right side vision is worse, I take right frontal basal approach. Come, identify the optic nerve, then debulk the tumor along the base of the tumor, debulk the tumor, debulk the tumor. You have to learn how to demolish the tumor. If you go on coagulating and go on coagulating, you may never end any neurosurgery. You have to break the tumor, break the tumor, break the tumor. And once you have broken, the thing which makes tuberculum celli meningiomas different is you have to identify the anterior cerebral artery early in the operation, very early in the operation. You cannot identify the anterior cerebral artery at the end of the operation. And if you identify anterior cerebral artery and then separate it, that forms the key to success of these operations. This simple operation should not be made into a mess by damaging anterior cerebral artery, any single perforator. That forms the bottom line of this operation. So this is another tumor which is, you see, the multiplicity is the issue. And when the tumors are multiple, I have already mentioned that these tumors are relatively straightforward. When you are seeing the tumor, you have to see the consistency on T2 weighted image, the relationship with the anterior cerebral artery, the relationship with internal carotid artery. So these are some preoperative and postoperative images. This is a little bit eccentric, and you see this is postoperative. You have to remove the tumor which is going towards the pituitary gland. And I have already mentioned to you, never in my series I have damaged the pituitary stalk, because there is always a very discrete plane of separation by the arachnoid membrane. This is another tumor with calcification. You see calcification. So what you have to do is come frontal, identify the optic nerve, then start separating the tumor from the base, debulk the tumor, identify the internal carotid artery, anterior cerebral artery, separate each and every small little perforator. I will say you damage one perforator, you may just be safe or you may not be safe. But damaging any vessel is the ultimate disaster you can have. You can have from a patient who is completely improved in a vision to have various deficit, and you can have a dead patient. So you cannot, this simple tumor should not be made into a disastrous outcome by any single arterial damage. This is another tumor with calcification and tuberculum celli meningioma. You see the postoperative right frontal or left frontal. This is another tumor, which is, I removed this tumor in not more than 20 minutes. And time is not the issue, but you see there is a necrosis, there is softness in the tumor. I broke the tumor, and dissected the anterior cerebral artery and other arteries from the tumor. This is preoperative and postoperative. Beautiful resection, beautiful outcome. This is a tumor with, and I mentioned about the lobulations encircling the artery. It is not that the tumor is going right from the middle of the tumor and then you have to dissect and all. These are under the lobulations. And if you break the base, and then these lobulations can be dissected in a very safe manner. This is another tumor. What makes this difficult is little bit darkish, little bit calcification, encasement. So this requires all the fun of neurosurgery, of breaking the tumor, dissecting in the subarachnoid plane, dissecting the artery, having the challenge, going in the optic canal if the tumor is going, remove the tumor from the canal, and you have an outcome and the person is cured. These are benign tumors. So this is a beautiful neurosurgical operation. And I have mentioned quick operation if you know how to demolish this from the base and then demolish from the surface. This is another tumor. You see, this was also beautifully resected. This is another tumor. You'll think that the whole thing is encased by the tumor. But you break the tumor, and then identify the anterior cerebral artery, dissect the anterior cerebral artery, and remove the tumor. This is another tumor post-operative. So as I have mentioned, I have got 300 cases of this kind. And this is my beauty of the hospital where I was working, where is public hospital, free charitable hospital. You see this tumor which goes in the cavernous sinus lateral wall, internal carotid artery encased this manner. And then you have to go in a more lateral exposure, diurnal calcification. And here also I see my flap very lateral. Normally for tuberculum celli meningioma, my flap is a little bit front. But when it is the internal carotid are more in danger, like in this patient, then my approach is a little bit lateral or diurnal. This is another. When the tumor goes a little bit anterior, like planar sphenoidal and olfactory group, the surgery becomes relatively simpler. There is no need for bilateral approach. Unilateral approach is good enough and beautiful. Break the tumor, dissect from the base, and then debulk the tumor, identify the difficult, dangerous zones, and then remove the tumor. So now I will show you this tumor. This is preoperative. You can see the anterior cerebral artery and all those things. This is a almost completely unedited tape. Okay. There is the whole operation which I'm going to show you is very, very little edited, if at all. So first thing is, this is right frontal exposure. First thing is learn how to relax the brain by going laterally, opening the sylvian fissure. my point in going frontal is that you can see both the optic nerves relatively easily and then dissect the tumor from the optic nerves, both sides, and then internal carotid artery and anterior cerebral artery from both sides. So now you see, now I'm coming and identifying the tumor, which is most, I cannot, I am not saying this is a difficult tuberculum celli meningioma. Now you see I'm dissecting the brain and showing the tumor. Little bit editing has been here. Now you see what I'm doing is, this is my suction in my right hand. I'm not coagulating, but cutting the tumor from the base of its attachment. You see, now I have identified the optic nerve here, which was right inside the tumor. Very, very rarely optic nerve will be, inside the dome of the tumor. Optic nerve, here the anterior cerebral artery, which is a very, very critical part of the operation, as I have mentioned. This patient was completely blind in this right eye, and here is the internal carotid artery. Now I am dissecting the tumor from the base, and you see I have now taken the optic nerve has been a little bit released. The tumor is firm, as you can see. So I'm rarely use knife in this situation, but here knife has come somehow. So I am cutting the tumor. Now you see how, imagine, now I have lifted the tumor from the other side, is relatively easy. See, in neurosurgery, we should never use the words easy or simple or something like that. These are not the words to be used in, we are dealing with very critical organs of the body. This is the opposite optic nerve. More important is, you see this patient was completely blind in one right eye. Normally, I don't remember what the patient had or what the patient did not have. But here I know, because this patient was a little bit of a VIP patient. Not little bit, quite a bit of VIP patient. So this is the tumor which I am separating. You see here, anterior cerebral artery. And I must tell you that this is not too much editing here, not editing. So whole operation, if you realize, maybe finish in 10 minutes maybe. And if you also realize one thing, that there is hardly any coagulation which I do, despite the fact the field is little bit red, but coagulation is not there. Because in my life of neurosurgery, I have loved to enjoy the red color. I don't like black color too much. You see now here, the optic nerve is completely, quite dramatically stuck to the tumor, which very rarely, I will say this is a very rare phenomena in such a tumor. And if you think this pituitary stalk, I have not even dissected. The whole thing is away. Pituitary stalk, you don't have to, it's quite a, this is the opposite side. I'm just trying to see what is going on here. You will see the optic nerve on the other side, the pituitary stalk is there. These are common things. Every one of us has seen on multiple occasions during our life in neurosurgery, and tuberculum celli meningioma is a very common neurosurgical operation. And see, this kind of optic nerve stuck is a very, very rare thing, I must say, and I'm not sure whether I've ever seen it. Similar kind of thing I've seen in any other patient. So this is the post-operative situation. This is another case, pre-operative and post-operative. This is the anterior cerebral artery post-operative. This is another case, pre-operative and post-operative. And I had put on the World Federation website several of these cases on the site when I was the, the website of World Federation I was running. So this is another tumor. Let me show you. This is another case. Let me show you an unedited version of this tape. First thing is relax the brain. Second thing is identify the optic nerve. Third thing is, you see there's such a relaxed brain, and you see this dissection now, you know, I'm cutting out the tumor from the base, keeping the optic nerve separate. And you know, this is, I can use coagulation if I have to use. I'm not saying don't use coagulation and all, but I don't like it too much. If it is really spurting away, I may use it. But basically what you have to do is break the tumor from the attachment. Don't come on the dome of the tumor early in the operation. Then what you have to do is, once you have got the field under your control, then you have to identify the anterior cerebral artery, and then you have to save each and every perforator without any question about it. And if you have not saved a single perforator during the surgery, you might have a disaster at hand. So if the dissection is becoming a little tricky or not safe, you might like to leave some tumor behind. If you are finding that the dissection of the tumor from any blood vessel which is normal, you have to leave tumor behind. You cannot take the risk. This tumor which I'm showing you is in a workshop which I had conducted in Mumbai. And in 2 days, if Suresh Nair will remember, I had done 17 cases in 2 days at that time. I'm again saying this is my own style of surgery, this is from the workshop. I did this tumor in 10 minutes, as you have seen, as you will see. You have to know these tumors, you have to have the experience of these tumors, and more importantly, you have to be safe and sure, because these are benign tumors. Meningiomas are benign tumors. Meningioma is our life. We grow up with meningiomas, and we have to make patients live with meningiomas. Once a meningioma, always a meningioma. Patient will live with meningioma. You cannot cure a person of a meningioma. How to pull, where to give traction are all the things that you have to learn from your experience over the period of time. And you see, this is the tumor which is finally out. And this is the anatomy which is very frequently seen in our field of neurosurgery. So suprasellar meningiomas are difficult neurosurgical operations. If successfully performed, both visual and long-term outcome is beautiful, excellent. The utility of my grading system will have to be assessed. Recently, Laligam Shekhar has used my grading system for his own paper. This was my paper 17 years ago. This is my another classification of anterior clinoidal meningioma, which I will not discuss today, which I had presented in the year 2000. So 21 years ago, where I had described various parameters about vision, about size of the tumor, about relationship, which I will not discuss. This is another thing, olfactory groove meningioma, which I presented in, which is, as has been mentioned, the largest personal series. And I had given my own classification about olfactory groove meningiomas. So in short, to conclude, once a meningioma, always a meningioma. You remove the tumor, the whole tumor, and nothing but the tumor, without removing the ability of the tumor body to form a tumor. All meningiomas are classified into two broad groups, good or bad by hindsight. Like after 5 years, you say, I removed this tumor, patient is well. And after 2 years, the tumor has recurred. So you never know which will recur and which will not recur. So you must realize your infinite potential to harm the patient. You must remember this, and you must act accordingly. Curing is non-issue in the treatment of meningioma. This is a very big statement to make. Another huge statement to make is the recurrence of meningioma is independent of the extent of tumor resection. So you have to be restrained in your approach, and then you are less likely to disturb me. Conclusion, you have to resect the meningioma radically. Patient should improve in the symptoms. If symptomatic recurrence, then reoperate. Role of radiotherapy is absolutely questionable. So thank you, my dear friends, and I hope you enjoyed this journey of tuberculum celli meningiomas with me. Thank you.
Thank you, sir, for this excellent and insightful lecture, for showing us philosophy of meningioma treatment and showing us the surgical nuances of dealing with these tumors. And this huge experience has been really delightful. Thank you, sir. And we'll have questions at the end. We move on to the next talk. To introduce Dr. Raip Chirian, I'll invite Dr. Parthiban, who is a senior consultant at the Goel Medical College, Goel Medical Center, and we've all heard him on multiple occasions. His passions are spine surgery and microneurosurgery, and he's pretty well known in the Zoom surroundings. Dr. Parthiban.
Thank you, Abhida. It's a pleasure to introduce Dr. Raip. And I was just thinking, what is there to introduce AIP? You know, AIP is well known all over the world. One specific thing I want to mention is that, and soon he'll be called as Mr. Cystonostomy, right? The reason is that the forward-looking and innovative thoughts, like Atul was talking about, our Indian neurosurgical fraternities find the new generation, the new waves of neurosurgeons were coming up, and AIP is one among that. And his concept on cystonostomy has already fired up the world, and it is going to be very tough in future that we see that cystonostomy will become an important surgical technique, and he will be finally be called as Mr. Cystonostomy. I think that is the only way I can say.
Bhakti, it is an honor to be talking amongst all these giants.
AIP, your audio. AIP, your audio.
Can you hear me now? Can you hear me?
Yeah, better.
Yeah, that's better.
Yeah, I was just saying it is an honor to be amongst all of you. And it definitely, after having listened to Professor Goel and Professor Chandrasekhar, I had discussed with them, and I thought maybe if I talk anything more on analytical fossa meningiomas, there's absolutely no point, because we have heard some really extensive and exhaustive talks by both Professor Goel and Professor Chandrasekhar. So I would rather go ahead and talk something which is new. You know, I always believe in the principle that we must invest in the future. And to invest in the future, what one should do is to be ready to let go of the present. And if one cannot let go of the present, then you can never look into the future. So this has been a hallmark with Dr. Atul Goel, and it has been always inspiring for me that I always try to see what can be the next step. In the last 1 week, I must say I was isolated because of the COVID. Although I didn't have much of a symptom except a very irritating urinary colic. But other than that, I didn't have much symptoms of COVID as such. But I decided that I'll go to the lab and work to figure out what is the exoscope about. So that's what I'm going to show you today. I just shared my screen. So I hope you can see. You can see? All of you can see my screen.
Yes, I.
Yeah.
Yeah, so we brought
So this is the escalar AEOS. So this is the complete exoscope, which doesn't have any eyepiece, objectives, nothing, just a digital camera. And you can see two screens there. So the camera is based on a universal robot system, and the camera, what the camera sees in 3D is projected to these two screens, and the surgeon uses them to operate.
So this was what we started working with. Now, a few things I found with the exoscope was that the field of view, the depth of field, and adjustments, minor adjustments are much more easier than the microscope. It's because one of the reasons why it was easier was because you don't have to hang around into the eyepiece. So once you get it into focus, you can fix the focus, and then you can have the scope to move around everywhere. So from multiple angles, you can see it. It's called pivoting. So by pivoting, you really don't have to follow the scope. The scope will go wherever, and it will always be focused into the center where you have focused. So we started doing small procedures. We started off with a melon. We went inside the melon and looked at it. And then finally we went on to anastomosing at almost 50 to 90 zoom. So that's what we went ahead. Now you can see that we are doing very fine suturing on this chicken wing vessel. So this is what, and you can see the magnification zooming out right now. So starting from about 2 zoom, go all the way to around 50 zoom. 10 zoom is the optical, but then the digital zoom is also fantastic because the camera's quality is just truly amazing. And the 3D depth is, the stereo depth is also amazing. So you can, and the entire operation can be looked at and controlled by the foot pedal. So I find that after a while, I'm sure that this would take over from the microscope. That's because, first of all, like for example, in a sitting position and all that, which is a position that I love. And earlier we used to put endoscope up on the pneumatic arm, but then with the exoscope coming, it would be a completely different picture. And by the way, it has got ICG and ALA also. So it is not far behind the microscope when it comes to functionality with respect to these kind of things like ICG, ALA and things. So the only thing is there is a learning curve, and somebody who's using the microscope, it is not, very easy to suddenly shift to the exoscope. So we took about a week to get oriented to it, especially the foot controls and such. Of course, you can use the hands to position the, see like that, you can use the hands to unlock and then position it where it's a back drivable robot. So you can position it wherever you want. And then from there, you can start functioning. So you can do this with your hand or with your foot. I prefer doing it with my foot because when you use with the hand, when you use the hand to move at very high magnification, you can tend to go out of focus. It autofocuses every second, but even then, I would like to do it with the foot. So that makes it much more easier. So this is what we've been doing. Now we've not done it in any cases. So this is the lab that we are working on with the AEOS. It has got this 26-inch screen, and behind that you can see the large screen, 55-inch 4K screen. So you can see the magnification at which we are working. This is a 0.6 or 0.7 millimeter vessel. And you can see that's my wife. So both of us are sitting together and working with my people in the lab and trying to get the hang of it. Whatever we've seen till now, we really like it. And I believe that very soon I can make the shift from my Kinevo to the AEOS. So I'll keep you guys updated. Also, we've got the 3D endoscope also. The Escolab calls it Einstein Vision. So it is very easy to use the endoscope, the 3D endoscope in lieu, I mean, in conjunction with the Exoscope. So much more easier than the microscope. So for this 3D endoscope, we've also got a robotic holder. It is a Franca Amica arm. And this arm can also is back drivable, so you can position it wherever you want. And using NeuroPilot, you can take it up, down, X, Y, Z, all the axes it can take. So with this, we believe that minimally invasive surgery will be a completely different cup of tea. It is completely, and we are also working with this ophthalmic instrument group, Apasami. So we are designing instruments which are much more smaller and precise than the usual microsurgical instruments available now. So we hope in the next 1 year or so, we will have something to showcase to you. I mean, cystonostomy, as Parthiban said, I'm happy to have been involved with cystonostomy. But then it's time to move on right now. 15 years I've been with cystonostomy now. There's no need to hold its hands and move forward because people are already doing that. So now I need to get into something which is new. Another 5,000 more days, which means another 15 years before I probably can call it a day. So this would be my new project. So innovations for making neurosurgery more ergonomic. And another 2 minutes, I would like my surgical resident, Dr. Nihal, to present on what is basic exoscope. That will take about 5 minutes. And Dr. Hari Singh is also here, my team. So 2 minutes, I mean, I'll give them about 2 to 5 minutes to present on the what is the basic idea and what is the difference. I mean, this is for residents, and because this is a new thing, completely new thing on the market, so we would like to present that. So I would invite Nihal, please. Nihal.
Good evening, all respected teachers.
Good evening, panelists. It's first of all, I would like to express heartfelt gratitude to my professor, Professor Ike, because it's really a great opportunity to be presenting, even though a small presentation amongst eminent neurosurgeons as you. So I just want to start by asking a question. Exoscopes are a boon or a doom? Well, the simple answer for this question, it is obviously a subjective opinion rather than an objective opinion. But anyhow, even though subjective, this doesn't prevent us in discussing the advantages and disadvantages of the exoscope. Let's discuss among some of the advantages and disadvantages of the same so as we can formulate our own views about whether to use in our further careers or not. Let's see firstly about the brief history wherein in 1957 the first use of the operating microscope was shown, and up till 1967 the history continues wherein the superficial temporal to middle cerebral artery anastomosis was done under the microscope by Goel. But this was all under the operating microscope. Today we are here to discuss about the exoscopes, which is basically the operating microscope, but without any kind of lenses. Now, there are different types of microscopes which may be classified as surgical microscopes and exoscopes. Surgical microscopes, we all know the examples would be Leica and Zeiss Pentero 800. Whereas exoscopes are relatively new in the market, we have, as Professor Cherian showed rightfully, that we are using Esculap AEOS, that is a type of an exoscope. Now, exoscope is derived from two Greek words, that is exo, which means out, and scope, meaning to look. There is also a system in the market called as a hybrid system, which is the combination of stereoscopic microscope as well as an exoscope. Example would be Kinevo, as we have it in our hospital. Now, just discussing upon the advantages, they have a better ergonomics, as shown in the picture. We don't really need to orient ourselves as the digital image shows rightfully onto what is being projected inside the cameras. They obviously have better magnifications up till 95x, as shown in the previous videos. They have outstanding precisions and better field of view. By meaning that in cases of stereoscopic microscopes, they use prisms and lenses. And although we have come a long way from small lenses to high-powered lenses, we cannot argue the fact that there will be persistence of aberrations such as chromatic and spherical aberrations. But anyhow, these exoscopes, being projecting the images digitally, they will minimize and literally nullify all these aberrations, so as they can give us the best quality images which can be seen. And of course, not to mention, they have better integration with other devices also. But as there are two sides of the same coin, we have to also discuss about the downsides, like they have higher learning curve, and there's also a delay in the transmission of video footage by 1/500th of a second, because it is a video footage which is being captured by the cameras and then displayed by a video monitor. It is not the same as observing it under a lens or a high-powered lens. And obviously, it requires more software optimization, as now it is recent in the market. It requires further developments. And last but not the least, the major concern, they are more expensive than the stereoscopic microscopes. But to end, I would like to tell that with professors like eminent professors like Professor Cherian and other panelists which are present around here, who can guide us through every step of the way, the benefits of using the exoscopes literally outweigh the disadvantages faced. Hence, I feel that it is a boon for the modern neurosurgery. Thank you.
We can have our question answer session for all the three. I am done here. Thank you very much.
Thank you, Aip. And we are looking forward to you coming up with some new cases using the exoscope very soon and using this technology. Thank you for this demonstration of the Kinevo. Now I think we have Dr. Suresh Sankla is going to present some cases.
Shall I
Yes,
share my screen?
Yes, yes, yes.
Yeah. Thank you very much for giving me an opportunity to share my experience. Although before I start, I would like to say that a lot has been already spoken about the meningioma, the suprasellar meningiomas by Professor Dev Pujari and Professor Atul Goel. And if you frankly ask me, there's hardly anything left for me to really describe. But whatsoever, I would just go over some of the technical steps of transnasal, transnoidal extended approach for the removal of tuberculosis meningiomas. This is one of our patients whom we operated a few years back, 52 years old female with frontal headaches and progressive loss of vision. And these were her visual fields on admission. We decided to do surgery using the extended approach just because the tumor was not looking firm. It was position was strictly midline. It was not extending to one side, and it was approachable through the midline approaches such as the transnoidal approach. Also, the tumor extension was not too much. It was very close to the right optic canal, but not really invading into it. And the anterior cerebral vessels were not involved or encased by the tumor. So we thought this is going to be a very, very appropriate case for transnoidal endoscopic approach. In endoscopic approaches, there are several difficulties, as Dr. Dev Pujari has mentioned, and some of them are really very, very significantly can affect the outcome and the surgical dissection. I just lost my vision.
You can restart.
Yeah. Okay. No, it's started. I just got transient because of this phone call. So one of the important thing is the skull base anatomy, and that is often distorted because of the severe hyperostosis that you see during in many of these patients. And some also affecting is the configuration of the tuberculum sella as well as the sellar cavity, and that makes the life miserable at times, and you have to stop surgery because of the unavailability of the correct anatomical orientation. So the drilling at the skull base is very important, and this is how you should do. And this is the sphenoid sinus, and you start taking the bone off from the skull base, and this is the tuberculum, this is the sella here, and we really keep all the anatomical landmarks right in front of you during this surgery. We often use the diamond drill so as to drill this bone, which is invariable in consistency. At times it is very hard, at times it is very soft, and you may injure the intracranial structures if you are not very careful. So this is how you do the drilling, and then you remove all the bone, and these are the structures available to you right in front of you. So this is the sellar region, and then this is the suprasellar tuberculum dura, and then this is the suprasellar dura. So how you start opening the dura, that depends on your imaging showing where exactly the tumor is located. So if the tumor is located entirely in the suprasellar region, you don't have to open the sellar dura. But if you are not very well oriented or doubtful, then you start with the incision in the sellar region, and then you extend it upwards. So this is the transverse incision in the suprasellar region now, because we knew that the tumor is located right in the suprasellar region, and not much of the tumor going into the sellar region. So as soon as you open it, you are in the suprasellar cistern, where you can see the frontal tips of the frontal lobes and the interhemispheric fissure, which is right there. And this gives you a very good anatomical orientation. At the same time, you see the upper limit of the tumor, which is here, the tumor capsule. You can see right in front of you as soon as you open that part of the dura. And then you proceed the dural extension laterally as much as you are comfortable, as much as required to expose the lateral extension of the the tumor. Since this tumor was smaller than 4 centimeter, 3 centimeter, we were very comfortable opening it laterally under direct vision. And then you take a midline incision of the dura and go into the sellar dura as much as it is required. If it is not required to expose the pituitary, I don't think it is advisable or it is correct to open the sellar dura. Once you have done that, then the ideal dissection technique or the standard microsurgical dissection technique should be applied, such as the decompression of the tumor, which you do initially so that the tumor remains, or the tumor capsule becomes very, very lax. The tumor mass becomes smaller, and it becomes very easy to mobilize the tumor capsule from the lateral part. So this is what we are doing. The first thing you do here is to look for the arachnoid plane. And once you find the arachnoid plane, and once you are comfortable having a plane of cleavage between the tumor capsule and the suprasellar arachnoid, then you are very, very comfortable, and you are sure that you may not damage any of the intracranial neural or vascular structures. So here we can see the left optic nerve, which has been pushed more laterally, as you can see on the preoperative imaging. And this is the arachnoid. The suprasellar arachnoid is here, and this is the optic nerve, this is the optic nerve, and this is the tumor capsule. So you can easily dissect this tumor capsule away from the arachnoid of the optic nerve and the other structure. Here you see the anterior cerebral artery, which is quite far and away from the tumor capsule. If at all there are some arachnoid strands which you can really remove or dissect by using a blunt or sharp dissector, whichever you are comfortable with. And this is the optic nerve, which is now looking quite lax and can be easily dissected away from the tumor capsule. This is the anterior cerebral artery. Strictly remaining in this place, you just continue your dissection more superiorly, and you find that your anterior cerebral complex is completely opened up and completely exposed and dissected freely from the tumor capsule. So this is the ipsilateral and the contralateral anterior cerebral artery, A1, A2s, and then the ACOM here. And these are the dural strand. This is the arachnoid of the frontal lobe, which are easily gently pushed away from the tumor capsule, and the arachnoid is opened up. But once you have done that, then I think you should go into it and try and find the infundibulum or the pituitary stalk, which according to I agree with Professor Goel that it is very easy to find and very easy to dissect away, because there is always an arachnoid plane around it. So that is what we are trying to expose, and you separate the dural, the tumor capsule, and try and look for the pituitary gland. So this is the pituitary gland, the superior part of the pituitary gland, and then you follow it up and you will be able to see the pituitary stalk here, very well preserved and very well separated by the arachnoid plane. You can easily separate it slowly, keeping the same dissection technique, as well keeping the same plane which you have earlier identified between the tumor capsule and the arachnoid of the pituitary stalk. This is the dorsum sella, which you see behind the pituitary stalk very clearly. If necessary, if you find that tumor bulk is much more, you stop doing this thing for a while and do the tumor decompression a little bit more. More and more debulking will make your dissection much more easier. This is the chiasm now. You can see very well the anterior part of the chiasm, and this is where the perforating vessels you may find, and you have to preserve those things in order to preserve the vision. And this is one advantage of this approach over the transcranial approaches, that you can preserve the blood supply and the perforators of the inferior surface of the optic nerve, inferior as well as the medial surface of the optic nerve and the optic chiasm. And that is probably responsible for a better visual outcome in most of these patients, as opposed to the transcranial approaches. So here, this is towards the end. You can see the entire ACOM complex, the optic chiasm, and the blood supply coming from superiorly and the blood supply coming from the inferiorly to the optic system has been completely preserved. The brain, which has been pushed up superiorly, is now slowly falling back to its normal place. Here you can visualize under direct vision if the tumor is extending into the optic canal. And if you see that, you can just release some of the dural attachments and then drill away the medial and inferior part of the optic canal, and then remove or resect the tumor completely and achieve a good tumor decompression. This is how we close the defect. We first close the dead space using some of the adipose tissue taken from the patient's abdomen, and then we put a pericranial graft. This is just the inlay graft, and which makes sure that the fat which has been put into the tumor cavity stays there rather than it falling back because of the gravity. Whenever it is possible, we take a small piece of bone or cartilage to really reconstruct the cellular floor and the defect that we have created by drilling the bone from the tuberculum sella as well as sella. And then the final closure, the final layer of the closure is the here is the graft, which is that flap, which is a vascular, very generous flap, which we raise in the initial part of the surgery. This is a mucosal flap, which is very lax, has its own blood supply, and it covers the entire defect very, very nicely, and it avoids the post-operative CSF leakage and pneumocapillus. And this is just some of the glue which we use to keep this graft in position, and then the rest of the nasal packing is done in the usual fashion and kept there for 2 to 3 days. We usually on sixth or seventh day, as well as on the fourth day, put an endoscope into the nasal cavity and make sure that this area is completely covered and there is no CSF leak or any part of the graft is loose and lax. Once this has been done, this is how we do this thing. And these are the post-operative scans of the same patient showing a complete resection of the tumor. And you can see a nice flap which is covering the entire defect which has been created as an extended approach to remove this tumor, has been completely covered by this technique. How much time is left? If there is enough time, I can show another case also.
About 15 minutes.
3 minutes?
15
minutes. Okay,
yes.
Lovely. So I can show another case, which is an olfactory meningioma. This is a 17-year-old girl who had multiple meningiomas, including one in the olfactory groove, and she presented with loss of smell, followed by headache, vomitings, and visual impairment. And we decided to remove this tumor using the nasal approach, one of the extended approach. The good thing about this tumor was that there's a nice cortical flap, which has been described which has been mentioned by Professor De Pujari in his presentation. This is a sign of great safety, and if you have a nice cortical thing in between the vessels and the tumor capsule, it is a very safe point to go ahead with the transnasal point. Besides that, I consider most of these olfactory groove meningiomas as cortical meningiomas at the skull base, and treat him accordingly. So this is the transnasal approach, the typical sphenoid sinus, which you can see. You can see the contents of the sphenoid sinus, including the sella turcica, the floor of the sella, sorry, and then rather than going into the sella and removing the cellar septi and all that, you go more anteriorly. This is where in the crista galli area, in the olfactory groove area, where usually because of the hyperostosis, you find a very bulky tissue around it, which is sometimes soft, but most times it is very, very hard, and you need to drill this part completely in order to have a proper access in that area. So we start removing the soft tissue, the mucosa from there, and then you do the drilling.
भाई साहब तू मेरे को कौन सा माइक्रोस्कोप दे रहा है? देख टीवा तो तेरा अच्छा है, वो ठीक है, पर अभी एक नया
So you can do the drilling, and as you start drilling, you will realize how tough it is to really dissect or remove this bony area which is lying right underneath the tumor. These are the frontal sinuses which you see more and more towards the end of this drilling. Once this drilling, at times the normal landmarks are totally masked or hidden by the hyperostotic bone, and you may need to take the help of the intraoperative navigation. But most of the time, if you are strictly in the midline and you are able to see the normal landmark, it is quite okay to go ahead with drilling the bone and expose the dura. So this is towards the end. The entire bone has been drilled away. And then the dura, which was stuck to the hyperostotic bone very, very densely, and sometimes it has been already removed or lacerated by the tumor involvement as well as by the drilling, then you can see the tumor right away, like a cortical meningiomas. And this is how I find them little easier. So you don't have to do anything. Once you have drilled away and the dural edges has been completely excised from here, until you don't see the tumor involvement of the dura, then you start decompressing the tumor. And there is a nice cortex seen between the anterior cerebral vessels and the tumor capsule. You can go ahead and decompress the tumor until you are encountered with the capsule or the last part of the tumor. This is the frontal anterior inferior part of the left frontal lobe, and this is the right frontal lobe, which is still covered by the tumor capsule and part of the dura. Here the dura has been completely resected because it was totally involved by the tumor, and rest of the tumor, particularly the last part of the tumor and the tumor capsule, require a meticulous dissection in order to separate it from the normal brain, and to ensure that you are not really injuring any of the vascular structures which are lying right behind this tumor. Although we were sure that there is a normal brain, a layer of normal brain between the tumor capsule and the tumor and the normal vessels, but still you have to be very careful at this point and make sure that you are not really injuring anything. This is towards the end. Every part of the tumor has been removed, including the tumor capsule. You still don't see the anterior cerebral vessels, and some of the oozing is coming from various corners and all that, which is easy to excise, and it stops on its own once the tumor has been removed completely. And you have ensured that the tumor has been removed completely, and this is towards the end where everything has been removed and the brain has been completely decompressed. And as you decompress the brain, you will see that the frontal lobe falls down due to the gravity. Here, the only problem is that you don't have a head flap available to cover this defect, and most of the time you have to use different techniques or taken flaps from the other areas, from sides and from the superior part. If you are lucky, you may get it, but you have to rely on the different techniques. So we fill the gap created by the tumor removal by some piece of adipose tissue and fat, and then covered it with the Duragen, which is an artificial dura available nowadays, and it is covered in place with the Duracell. And then this is the part of the fascia lata, which we observed, which we took from the thigh and then put it here in order to really cover the defect completely. And then the rest of the nasal cavity closure and packing is the same as we have seen in the other approaches. These are the post-operative scans. So this is how we have created the window through which the tumor has been removed completely, and then the nasal pack has been put and made sure that the packing has been, or reconstruction has been quite okay, which you see on the post-operative imaging. But intraoperative, as I said, third or fourth day at the time of removal of the nasal packs, we put the endoscope in and make sure that everything is all right. And there's no CSF leak or any part or the corner of the graft hanging down and creating problems later on. And these are the post-operative. This is the post-operative scan showing complete resection of the tumor. And I thank you very much for giving me this opportunity to share my experience. And I stop sharing and take some questions. Thank you very much.
Thank you, Suresh, for that wonderful lecture. And considering that, because of short of time, we have been instructed by John Bennett that we are having another symposium of Victor Perez on anatomy. So let us go there. But before I wrap it up, I like Suresh, you are there, Suresh Nair?
Yeah, I am there. I am very much
Suresh,
there.
I want you to just summarize the whole show. And if there are some burning questions you may like to ask.
Look, really, I loved all the lectures and wonderful lectures by all the speakers. But, something which I think was not addressed was, so we, as you correctly told, Atul, you told that meningioma is totally like fingerprint only. It's a heterogeneous group of tumors. And presently, we know that 25% of grade 1 and 2 tumors exhibit rapid recurrence despite total removal. And if you go by WHO grading grade 1, sadly 25% of them recur, even if we within the first few years. Now, do we have any other yardstick for measuring aggressiveness? Anything on genomics or proteomics for anterior cranial fossa meningioma? Question to Dio Pujari, Suresh Shangla, and Dio Pujari, all of you can answer if you know anything which has come up to measure aggressiveness, because all of you remove tumor aggressively, but still grade 1, 2 meningiomas, grade 1, they also recur fast. Anything?
Dev Pujari, you like to
as far as
any mutations?
As far as
any mutations?
I really do not know. I think all the markers for tumor growth have found to be deceptive. I think what we used to call grade 2 tumor, I think we have become a little more aggressive. If we find some atypicality in the tumor, we use radiotherapy much more easily today than what we used to do in the past. But beyond that, I really don't have any comment to make.
So, what has come, I don't know. Actually, there is some mutation called SMO mutation for the anterior cranial fossa meningioma. If it is detected in grade 1 meningiomas, they recur rapidly. So nearly 30% of the anterior cranial fossa meningiomas that recur. So that is something, some new advances are coming in genomics, proteomics, and epigenetics of meningioma. Because I read, why I read all this is, I have to give an oration on 30th of January for Chennai Ramamurthy sir's 100th birth centenary celebration. That is why I read. I was also not knowing. And second thing which I read, I don't know whether you addressed it, I don't know still, Atul, Suresh and you yourself, all of you told about say meningiomas, and both you yourself, Dio Pujari and Suresh Shangla told about both endoscopic and the last couple of years we have been hearing the pros and cons of transcranial and endoscopic surgery. But what I read, I don't know, I have no idea. Say there is one study from UCLA, University College of California at San Francisco, McDermott's group. What they actually brought out a score based on tumor size, involvement of the carotid and optic canal, and some 0 to 5, and they found that it has good prognostic indicator for eventual recovery and also recurrence. And what they have found is similar outcome for both endoscopy and transcranial. They couldn't find much different. But what they found is those patients whom they could do gross total resection, the recurrence was more for transcranial, not for endoscopy, because in endoscopy they remove the involved bone also. And very contrary to that, that study they told involvement of the carotid, lateral extension involving the carotid is a bad indicator for aggressive removal. And contrary to that, in 2020, another article came from Schwartz group in Cornell University, where he has told that size is nothing to do. They can remove the size of the tumor is not big concern, and also involvement of the anterior cerebral artery is not a problem. They also told that involvement of the optic canal is not a problem for endoscopy. What they have found is revision surgery, lateral extension and encasement of the carotid. These three things predict difficulty for removal in total removal in endoscopic surgery. Any thoughts on this for Suresh Angla and Deo Pujari? Because he told anterior cerebral artery is not a problem. While I just read one of the questions where Atul correctly told that to somebody's question, when the tumor is going up, what you do, like that, he correctly told safety of the patient is more important than proving that you can remove everything. Your thoughts on all this, all three speakers?
Yeah, but Suresh, I think what you said is very correct. We have still not been able to find the correct answer, whether endoscopic approach will be the right thing to do, or the microscopic transcranial approaches. And there's a lot of work going on. And as you have mentioned already, there are people who, do not really give much weightage to the arterial involvement or the optic canal involvement. Even with all those things, it is possible to remove the endoscopically the suprasellar meningiomas quite well. And recently I read one article from Prividello. He had even internal carotid artery involvement and largely bilateral anterior cerebral arteries completely encased, and still managed to remove the tumor completely. So I think we'll have to just wait and watch. There's so much work is going on all around the world. And in the next few years, probably we will come to the real point, which is, which tumor should be removed using which approach. As far as these mutations are concerned, there are lots of work going on the mutations as well, which will tell us in near future that which tumor is going to recur very fast, and maybe that will throw a light on our surgical approaches. I don't know Professor Goel's classification will have is having anything to do with the type of the tumor or the prognosis of the tumor as far as the grade 1 suprasellar meningiomas are concerned, if they can throw any light on the prognosis.
Shekhar,
Well, yeah.
we unfortunately we will have to stop now because John has some other commitment. So with
I think
you just wrap it up, say last few sentences, and we close it.
no, I will just say one thing, that I think DMEO first gave this classification, and Kuldwell's group has come out with recurrences mainly in the optic canal. The explanation for that is probably partly there in that Fernando Miranda's classification from San Francisco. The basic idea is that whenever you do not get to the lateral extent of the tumor, they are more likely to recur. I think that is something which everybody agrees, which is difficult to remove by the endonasal approach. But I look at this whole debate in a different way. I think that tumors can be removed in both ways depending on how you are comfortable. But there are cases where you are doing subtotal resections even by transcranial approach. Some of those cases your excision can be more complete if you also use the endonasal approach in addition to that. So I think as long as you believe that surgery is the mainstay of treatment and not the complementary radiation or upfront radiation, then we can probably talk about hybrid surgery in future to get more radical resections. Thank you.
Thank you.
Okay, gentlemen, everyone, thank you very much. I'm sorry we'll have to wrap it up. Next time, I'll allow more time because you obviously, everything's very interesting. I'd like to thank Atul, Chandra, and Ip especially. And we'll see you in 2 weeks. Do you guys have a topic yet for 2 weeks, Chandra?
Thank you.
I will send you, John, very
We
soon.
should
the
let you
topic,
know by
okay?
Monday.
Okay, Victor, you want to talk about your conference coming up in about 10 minutes?
Yeah.
Go ahead, Victor.
Thank you. Hello, everybody. Very nice to see you all.
Hello,
It's a
Victor.
pleasure.
What's your topic, Victor? You're talking about?
I'm going to talk about spinal cord, vasculature of spinal cord, but in Spanish.
Spanish. Okay, Caleb.
Much better
Okay.
for me. Much better for me to speak in Spanish.
And maybe a little ranchera too, right? Okay, thanks everyone. We'll see you in 2 weeks.
Bye-bye. Bye-bye.
Bye.